Welcome, everyone. We're going to get started with some introductory words from Dr. Phillipson.
Okay, that's great. So I was just waiting for that. Well, welcome everyone. We have a lot of folks on today, and that's terrific. We're going to start with some general introduction. I'm going to make sure that we also mention our wonderful speakers, Dr. Naylor, Dr. Dickens, Dr. Rosamina, who will do a short video, Dr. Gandolfi, Dr. Henkes. So we are all going to say a few words about this topic. I'm going to introduce our topic today and zoom out a little bit before we zoom in. So welcome again. And also the ground rules. So if you have questions, we can read them in the chat. So one of our group will be looking at the questions. If you have things of a specific nature that you don't want to put in the chat, you can certainly email us and we can then get back to you. Of course, we can't be doing doctoring, but we can give you more specific information or talk to your own doctors as well. So if we could start with the next slide, just to introduce some of the ideas that we have been doing the last few years. This is our agenda that I mentioned. So Dr. Gandolfi and Dr. Rosamina, Dr. Dickens, Dr. Henkes. So that's the topics for today. That's the Q&A, and we can keep going. So what we're going to start with is, again, the background to what we've been doing the last 25 or 30 years, and that will give you some idea of where we are right now. So then we have a conflict of interest disclosures, and you see there's a list of companies that we do contracted research with, none of which sadly have to do with monogenic diabetes, but we put them on the list anyway. So there we go. So the main point today is that there are many kinds of diabetes. We're going to be talking about one in particular, GCK, which has been known as MODY 2 in the past for basically reasons of which came first scientifically, and not because it's number 2 in anybody's mind. But the idea is that there are something like 40 million people in the United States with diabetes, of which mostly are the types that most people know about, type 1 and type 2, and everyone on this call, I think, is aware there are many others. Gestational diabetes, Dr. Dickens will talk about a little bit in terms of GCK in particular, but is unfortunately a grab bag of lots of different things. So it is women who have diabetes in pregnancy, but there are, of course, women who have diabetes before pregnancy, and we have, sharp definitions of all those different ideas. We're going to focus on, as you know, one kind of monogenic diabetes. So we were just on a call with one of the leaders of monogenic diabetes in Scotland, who pointed out that they have a database of everyone with diabetes in the country, and so they know pretty much exactly who has monogenic diabetes out of everybody. Their numbers are less than what we said there because it's 1 to 5% of monogenic forms of all diabetes if you look at younger people, so people in their 20s to 30s and younger. In Scotland, for example, we heard today that if you look at everyone with diabetes, children, adults of all ages, it's more like 0.1% of everyone with diabetes. So that's a different way of looking at it, and they have some interesting demographics and computer-generated, computer records of all of those folks. So the importance here is that it's very different from either type 1 or type 2, and making a diagnosis can be life-changing, as I hope some of you have experienced. So on the next slide, we have a little history that I put together for an earlier talk, and going all the way back to the 1970s and earlier. So we mentioned that some of the specific genes were identified here at the University of Chicago. Some of the key ones were in specific collaborations, one with Dr. Fyans at University of Michigan up until the 90s and the early 2000s with Dr. Bell here and some other colleagues that you can see there on the screen. Dr. Tattersall worked with a year with Dr. Fyans, but went back to the UK and and he passed away, but he has some useful things to write about, so that's helped spread the word. And as you say, as we go on, there are key groups in Norway and the UK with Dr. Hattersley and so on. So we're just going to focus on what we've learned from all these people. And interestingly, the quote there is from a paper that Dr. Tattersley and Dr. Fiennes put together a long time ago, right, 45-ish years ago, that there is what we call genetic heterogeneity. That means there's different kinds of genes that cause diabetes. And they said that even then, it is important that populations in which the genetics of diabetes is to be analyzed should be clearly defined as possible in terms of phenotype, rather than all put together under diabetes. So we think now there are upwards of 20 different kinds of diabetes, and probably more than that. And it's very important that we make the specific diagnosis. So on the next slide, we have really an overview from a cellular point of view. So we often think about how cells work. This is a sort of model, a cartoon, if you will, of an insulin secreting cell. And then we have different genes that are all around the circle. So some of them are on the left, but as you can see on the top right, we're going to talk about glucokinase. And the importance of glucokinase, GCK is the abbreviation of the gene, and MODY2 is what it was called clinically, is glucokinase is one of the key elements that regulates not only insulin secretion, but also liver regulation of glucose in and out of the liver, which is a key aspect of any sort of metabolism, but also is present in the brain, which is very interesting. And some of what Dr. Rosamina will say will also combine what we think is important there. So we have the next slide. So this is an example of the careful studies that Dr. Fiennes did in the 1970s and a little bit later. So this was a single family tree, and you can see it's actually 6 generations of people. And all of those dark colored squares, the round ones are women and the square ones are men. And the dark colored ones are people with diabetes. And what Dr. Fiennes figured out is that this kind of diabetes was strongly inherited from one generation to the next. In fact, it's called a dominant gene, so that each person, once the gene starts, and you can see in generation 2, we had people who were clearly defined. Probably somebody in generation had it, but they had passed away. So all of those people then in successive generations, each child had a 50-50 chance of having the same thing. And this was a different gene. This RW pedigree was the first one he picked out, which was eventually found to be HNF4 alpha, a different gene than GCK, but this is just for illustrative purposes. And that one was the first family that Dr. Fiennes put together. So clearly it was called MODY1. And we'll talk about MODY2 today. So we can go on to the next slide. So what we're going to talk about is how we've come to do this. Over the last 20 odd years, we have been working on a registry here. Many of you know, and most of you are part of it, that we've used to help people identify what mutation they have, to help doctors understand what mutations cause and what treatments might be best. In some cases, like today, when sometimes no treatment at all is the best. And we have now over 4,000 people in our registry, and we'll show that in a moment. And then we're also going to talk about a new thing we're developing, PREDICT, which is a national and now actually international consortium to study monogenic diabetes in more ways, so we get more people involved. And the next slide shows the registry numbers. So as of last year, we had about 4,500 people there. Now that includes people who have come to us maybe with type 1 or don't have a gene that we've identified. So out of those, over 1,500 have a known cause. And some of them, as you can see, are definitely MODY. Some of them are a little different, neonatal diabetes. And then we have a smattering of unusual things in the bottom. And on the next slide, we have our initial distribution. So we have in this country anyway, glucokinase, MODY2, is far and away the most common, at least the most common in our registry. That's very interesting because in many countries that is not the case. And in the UK, we were talking to one of our colleagues in Edinburgh in Scotland today. For them, HNF1 alpha is the most common. So we're not sure why that is. It may be a reporting artifact. It may be that we're not reaching all the doctors to have people join our registry. And theirs is a national registry of everyone. So we have a different kind of bias here. And then if we look at the next slide, you can see the family members who also have it. So what this kind of tells us is that glucokinase has the highest total number. So once we identify a person, we look at everyone else in the family. So the most associated are individuals with glucokinase. Now, what we think that tells us, among other things, is that it's relatively benign. People do well, live long, prosper, and we can then find large family members. Some of them have very few additional family members once we identify a single person. So they're vary considerably in how the other family members might also have the disease, whether the inheritance is dominant, recessive, whether it's spontaneous, and so on. So on the next slide, we talk about the goals here of our registry. So the idea of accumulating all these folks and all of you who are on the webinar today is that we need to learn more. As much as we've learned since, for example, glucokinase was identified in the 1990s, the glucokinase mutations, is that we still have stuff to learn, and there are still doctors who need to have more information in order to help you the best. So we're studying all these things, the natural history. We find that there are people who have, in fact, glucokinase and other things. So that's very important. We need to educate. We need to be able to understand how to explain genetic results. Cascade testing is what I was just talking about. That means additional family members who can be tested. What follow-up means, whether it should be done at all, and what needs to be done. How to identify new cases, and where, in some cases that are not related to today's lecture, what else we can learn from new ways of looking at diabetes. And on the next slide, these are the summaries. We talked about the monogenic diabetes registry, and one of the newest things we'll talk about, as I mentioned, is our consortium, which binds together many centers. And that's shown here. So our colleague, Michael McCullough, has helped work with some of our colleagues in pediatric oncology, people who study cancer in children, who've done an international consortium now for some time to better understand how to share data. So it turns out it's complicated, but we need to be able to show how many people we can put together from not only places around the country, but all over the world, to ask research questions when, as many of you know, the situation we're studying is relatively unusual. And on the next slide, we have some of the centers that are already signed up for this project. So we're very excited about this. And you can see we have people in Colorado and Texas, Boston, Cincinnati, Indiana, and so on. And then now several other countries have also been interested in joining this so that we can have the various participants protect their data, certainly protect the people who are participating in the studies, but also ask questions with bigger numbers of people about what we should be doing and what information we need to be able to understand. So then the next slide is exactly what I was just saying. So questions like, what happens in pregnancy in GCK-MODY 2, and Dr. Dickens will talk about that a little bit. Are there questions about children and growth and mood disorders, and how often should you check, and what's important down the road, and what does the data actually show? So we while this has been done in GCK in hundreds of people already, we think that many of these questions are incompletely answered, as your questions today will help us understand. And finally, I think this is now a handoff to Dr. Naylor, who's going to talk more specifically about glucokinase and monogenic diabetes.
Yes, thank you so much, Dr. Phillipson. So thank you all. Again, I'm Rachel Naylor, one of the co-investigators of the Monogenic Diabetes Registry and clinically a pediatric endocrinologist. And I'm going to talk about GCK-MODY, and I'm going to talk about it from the population level, meaning if we take people in aggregate who have GCK-MODY, this is what is true. So if I was advancing there we go. I was like, I was advancing just fine and then couldn't anymore. So GCK-MODY has a prevalence of about 1 in 1,000 people. So we're estimated to have about 300,000 people in the United States living with GCK-MODY. A lot of them don't know it, and we think that's actually not a problem because in aggregate, the clinical picture is mildly elevated blood sugars that don't lead to complications. We'll go into that a little bit more. But for the people who do have it and have been discovered to have elevated blood sugars or hyperglycemia, it is really important that they have an accurate diagnosis because it impacts what we do or what would be best to be done. So GCK-MODY or GCK-related high blood sugars or hyperglycemia is related to mutations in the GCK gene. This gene encodes an enzyme, and that enzyme is very important in our body's sensing that our blood sugar is rising and linking that increase in blood sugar to insulin secretion. For people who have GCK-MODY, all of that mechanism, that whole system works correctly, except at a higher set point. So the body will recognize that the blood sugar is rising, once it's a little more elevated than typical. So clinically, what we see is lifelong, overall pretty stable, mildly elevated blood sugar. This translates into a elevated A1C, sometimes only in the prediabetes range, but very often in the diabetes range for A1C. But because everything else in terms of if you have GCK-MODY in isolation, everything else works. The body can sense blood sugar going up. It can secrete insulin appropriately, and it can respond to that insulin appropriately. The prognosis or the overall outcome is that the microvascular and macrovascular complications, so that means like the nerve damage, the kidney damage, the eye damage, and the increased risk of heart attacks or strokes that are associated with, say, type 1 and particularly type 2 diabetes, are rarely seen in the population living with GCK-MODY. And pharmacological treatment is not recommended except during pregnancies, which Dr. Dickens will talk about. And a big reason for that is because it really doesn't move the needle. It doesn't move the needle on the blood sugar levels. And again, I will come to that. But we will illustrate this through a case. And this case is based on someone who is in our registry, but with details changed for their own privacy. So this patient was initially given a clinical classification of type 1 diabetes when they were 26 years old. The way that they came to be diagnosed was that they were having a routine physical exam and were incidentally found to have a mildly elevated blood sugar of 124 on a fasting blood glucose. That got followed up. It continued to be elevated. So A1C was checked, which was 6.1%, which is in the pre-diabetes range. And the doctor diagnosed this participant as having type 1 diabetes based on the fact that they had a normal BMI, and they did not have any signs of insulin resistance. They had diabetes autoantibody testing, and they were negative, but there is an entity of type 1 diabetes without the antibodies, like evidence for type 1 diabetes. And so this was the diagnosis they were given. With this diagnosis, they were started on insulin therapy at a reasonable dose, not excessively high, but essentially what we would call replacement doses of insulin. And they started on a pump to manage their diabetes. I feel like maybe my slides are repeating. They are. I don't know why. Forgive me. There we go. So they were on insulin for 13 years while carrying a diagnosis of type 1 diabetes. But even over that time, they came to say, like, something is wrong. I'm doing all the things and my A1C looks like this. I'm doing none of the things and my A1C looks the same. And lo and behold, they had genetic testing, which revealed a mutation in glucokinase. This is not their actual mutation, but this is a mutation that exists. And because they got diagnosed, a number of their family members could also get diagnosed through that cascade testing that Dr. Phillipson talked about. So going into a cartoon of the beta cell, so this is the insulin-producing beta cell, we see that when we see that glucokinase is involved in what we call our glucose metabolism. It's the first step, again, linking an increase in our blood sugars to insulin secretion, right? So for this process to happen exactly as we expect it to, glucokinase needs to function properly. But if you have one gene that functions and one gene that has a variant where it doesn't function the same way, then this will cause GCK-MODY. Going back to the patient, after 13 years getting the correct diagnosis, he took off his insulin pump. And what you're seeing is in red or pink, depending on how it's appearing on your screen, is the time that he was on insulin, and in blue is the time off insulin. And what you can see is overall, everything looks really the same, signifying that the insulin that he took for 13 years was in fact not doing anything. There are, again, this, give me a second. All right, I think maybe my computer is actually the issue in terms of advancing. So there are lots and lots of different GCK mutations or variants that have been identified, all causing GCK-MODY. Despite there being so many different ones, the overall clinical picture is very similar for all. People can do, again, all of the normal sensing glucose, secreting insulin, responding to insulin, but everything at a higher set point. So if we look at people and how well their glucokinase enzyme essentially functions, we can see that for MODY, for GCK-MODY, it functions, it's just downward shifted, which then translates to hemoglobin A1C that mimics the general population, or the population doesn't have diabetes, but again, upward shifted. And like all people, as we get older, our response to our blood sugars declines a little bit. And the same is true in GCK-MODY, so that over time, the A1C rises with age. When we look at studies, whether people were misdiagnosed with type 1 diabetes or type 2, whether they're on insulin or oral hypoglycemic agents, if we take them away, the A1C is not altered. And we do see that when people are put on medication, that is not actually altering the A1C. This is through the GCK, through our registry, looking at the population with GCK-MODY some years ago, we see that not only is the A1C not affected, but there is some harm to being on a medication that's not actually being effective for that individual, including significant hypoglycemia. And Dr. Dickens will talk about that as well in the setting of pregnancy, which is more complicated. GCK does continue to be misdiagnosed, and when it's treated, it drives up cost, it exposes people to complications when the medication is not actually able to be helpful. And so because of that, we think it's really important that genetic testing is readily available for, again, the 1 in 1,000 individuals we know are affected by GCK-MODY. So again, when we're thinking in aggregate, we know that when we diagnose GCK-MODY, we can take treatment away and the prognosis is excellent. Yet, we know, as Dr. Phillipson alluded to, and the reason that the PREDICT consortium exists, that there are lots of unanswered questions when we get into the nuances, when we get into managing pregnancy affected by GCK-MODY, and when we get into what happens if, say, someone has GCK-MODY, but also carries extra weight. At what point can we determine GCK-MODY is not type 2 diabetes? There's nuances that I know a lot of you have questions about, and that is why the registry and the PREDICT consortium exist. And with those questions, I'm going to turn over now to Dr. Gandolfi, who is asking a number of you what it is like to live with GCK-MODY and kind of those questions that are not fully answered.
Thanks, Dr. Naylor. So again, my name is Ann Gandolfi. I'm a pediatric endocrine fellow at the University of Chicago, and I've been working on this study with Dr. Naylor to find out more about what it's like to live with GCK-MODY. Next slide. And I have no conflicts of interest to disclose. So we're really looking to understand the gaps in the lived experience with GCK-MODY compared to that population level information that Dr. Naylor already discussed. So despite the data in aggregate, we know anecdotally that in the registry, people living with GCK-MODY may report symptoms related to their mildly elevated blood sugar levels, along with stress or distress related to their diagnosis. Many people, despite the evidence-based recommendations, may monitor their blood sugars or alter their diet and lifestyle choices for the purposes of blood sugar management. And many people also report taking glucose-lowering medications. And despite the evidence that GCK-MODY is not expected to cause significant microvascular or macrovascular complications, many people still express concerns about these complications in the future. Next slide. So This is a qualitative study which involved one-on-one interviews with people living with GCK-MODY, and the topics that were explored during these one-on-one interviews included the diagnostic journey that led to the diagnosis of GCK-MODY, perceptions of clinical management recommendations, including the recommendation to not pursue glucose-lowering medications, perceptions of complications, risk, self-management practices, including whether blood sugars are monitored and whether glucose lowering management, including lifestyle and medication, are pursued, interactions that people are having with healthcare professionals and lay people regarding GCK-MODY, and lastly, perspectives on potential future precision treatments for GCK-MODY, including what would be the goals of treatment and what balance of benefits versus side effects versus burden of medication administration would be acceptable for people living with GCK-MODY to be open to such a medication. And the long-term goal of this project is overall to improve patient-centered care and to support individuals living with GCK-MODY. So this project is still ongoing, but 24 interviews have been completed, and we are analyzing the themes that are emerging from the transcripts. And although this analysis is still ongoing, I'd like to share with you some initial themes that have emerged. So cost of a misdiagnosis is the first one. So the harms of being misdiagnosed with other types of diabetes were pretty striking during the interviews. Many participants described initially being diagnosed with either prediabetes, type 2 diabetes, or gestational diabetes, and then being managed according to that incorrect diagnosis. As a result, they were often prescribed medications that they didn't need. Many of the medications may have caused bothersome side effects. And beyond unnecessary treatments, participants often described adopting restrictive eating habits and experiencing significant psychological distress, which I think is well illustrated in this first quote that I've listed. This individual stated, "I did get really scared about developing type 2 diabetes, and I did find that I was quite nervous around certain foods, and it definitely affected things like my ability to eat out. I was told I couldn't gain a single pound." These feelings of frustration and guilt and failure were often, unfortunately, reinforced by healthcare providers, as illustrated in the second quote. They stated, "My endocrinologist wanted to put me on Ozempic. He wanted me to go to his weight loss clinic and do a 2-week liquid diet," which, as we know from the overall aggregate data, that this would not be an effective intervention for GCK-MODY and would just contribute to the psychological distress. Next slide. The next theme that emerged was being one's own expert. So participants often described having to come prepared to their healthcare appointments and feel like they were the ones having to come in and educate their provider rather than sitting back and being the patient and receiving the healthcare. So this is illustrated by this first quote of a mother whose daughters have GCK-MODY. She said that, "I feel like I'm the one having to educate, and it would be nice to see someone who actually was familiar with it and could support us versus me having to drive my daughter's treatment." And this next quote illustrates a participant who felt like, throughout their whole life having the GCK diagnosis, they were the one having to come prepared. And then this quote illustrates the relief they felt once they found a team that could care for them during pregnancy. "I did really appreciate having a team who knew what they were dealing with, and that I didn't feel like I had to come prepared. I could just be the patient versus the patient/researcher. I didn't have to do my homework before each appointment." Next slide. And then the last theme that emerged, we found very interesting, was this diabetes label and stigma. So there are issues that come with just carrying the diagnosis of diabetes, even after a correct diagnosis of GCK-MODY is made, because diabetes is in the name. And I think this is really eloquently stated by this first quote. "The fact that we put GCK under the umbrella of MODY sets you up to have healthcare professionals who don't know about it assume you have diabetes. One of my fears is having in my problems list in my EMR, quote unquote, diabetes, when it's not true. Putting it under MODY kind of does it somewhat of a disservice." And many participants shared that healthcare providers tended to attribute unrelated signs, symptoms, or abnormal lab results to diabetes, which sometimes unfortunately delayed the diagnosis of other medical conditions. One participant described a particularly frustrating experience when her mother was hospitalized, as demonstrated in this next quote. The nephrologist kept trying to blame a low potassium on the diabetes diagnosis, right? And we were like, this is absolutely not what's going on. It took 10 days to get diagnosed. And I believe a large part of that was like, oh, well, she's diabetic. So this tendency of providers to anchor on diabetes and blame diabetes for other things that are going on when we wouldn't expect GCK to be causing any of those things. And lastly, sometimes participants describe the frustration when routine tasks such as completing medical forms created confusion and unnecessary stress. This participant stated, anytime I go somewhere and you're filling out a form, it's like, do you have diabetes? And it's like, what type, one or two? And I'm like, neither. You automatically get put into this bucket of higher risk. And this idea of higher risk also came up when reflecting on the electronic medical record, when best practice alerts would automatically recommend interventions that are appropriate for maybe other types of diabetes, such as extra vaccines or eye exams or urine screening for protein, when we wouldn't expect any of these complications in GCK-MODY. And other participants expressed concern about being put into this higher risk category when it comes to things like life insurance. And these are the initial themes that have emerged, but there is more to come. As I said, the analysis is still ongoing. And thank you very much.
Thank you so much, Dr. Gandolfi. And thank you, again, if some of you on the call are ones who are participating, and many of you, the response was so overwhelming, and we're really appreciative because this is how we really understand what it is like to have this this condition. I always say monogenic diabetes is like the zebra of medicine, like, the unusual thing from the horses. And I would say that GCK-MODY would then be like the unicorn, even unique amongst both monogenic diabetes, and really being able to understand your perspectives is so valuable. Speaking of studies where you have contributed to understanding, we are going to have a presentation by Dr. Rosamena. She couldn't be here, so this is recorded. I checked my sound earlier and it worked. And so we are going to hope that that still is true. Dr. Rosamena was a fellow, an adult endocrinology fellow at the University of Chicago, and she is now an endocrinologist at the Texas Diabetes Institute at the University of Texas, San Antonio, and continues to be a colleague and collaborator in monogenic diabetes. Fingers crossed for, well, the fact that I can't even advance the slides is, oh, there we go. All right.
Hi, my name is Dr. Marilyn Rosamena. I'm a general endocrinologist.
I think we lost the sound. Is anybody else having trouble hearing?
So sorry.
Oh, I think it came back.
Okay.
It came back. Yep.
Hi, my name is Dr. Marilyn Rosamena. I'm a general endocrinologist at the Texas Diabetes Institute in San Antonio, Texas, but I was a former fellow at University of Chicago, and I wanted to share with you some results of a project we performed regarding sleep disturbances, glucose regulation, and resting heart rate in subjects with MODY. As a background, it's important to note that sleep disorders such as sleep apnea, short sleep duration, and sleep fragmentation are well known to be prevalent in people with other types of diabetes like type 1 and type 2. We know that optimal sleep should be between 7 and 9 hours per night, but we tend to see shorter sleep duration, so less than 7 hours, and sleep fragmentation, meaning multiple awakenings throughout the night in people with type 1 and type 2 diabetes. However, subjects with MODY haven't been well studied. With that concept in mind, we knew that we had to move forward with understanding if the sleep disorders and different sleep patterns are present also in MODY. We know MODY subjects are different because we see less rates of obesity, we see less insulin resistance, or most subjects don't have any insulin resistance, and then other comorbidities such as hypertension and hyperlipidemia are less common. Two concepts to keep in mind while I discuss the results are obstructive sleep apnea and resting heart rate. When we talk about obstructive sleep apnea, this is the most common sleep disorder and happens when our airway collapses while asleep. This affects oxygenation in the brain, which leads to multiple fragmentations and awakenings throughout the night. This can be detrimental to glucose control, blood pressure, and weight. Another concept is resting heart rate. This is the heart rate that we have while we're resting, especially while we're asleep, and it gives us information about cardiovascular risk. The higher the resting heart rate, the higher the risk, especially over 70 beats per minute. The findings of our two projects. The first project was a pilot study. We had 24 subjects with all types of MODY, and within that group, 6 subjects had glucokinase MODY. What we found was overall poor sleep quality and short sleep duration compared to healthy subjects that were age and sex matched. These control subjects were retrospective, meaning from older studies. Glucokinase, compared to other types of MODY, had better sleep quality, less variability, meaning night-to-night sleep duration was more or less stable, and lower resting heart rate. So this, in general, the conclusion is that the patterns of sleep quality and sleep disorders were better for people with glucokinase compared to others. Our second study included 123 subjects. So here we have a bigger population of glucokinase subjects, so 63. And the results here revealed that the glucose profiles were more stable, and we did see more time in range, so the glucose between 70 and 180 milligrams per deciliter, and less hypoglycemia. Additionally, sleep apnea was present in all the groups, but at lower rates in glucokinase compared to other types of MODY and even controls. Additionally, glucokinase compared to other types of MODY had lower resting heart rate. So overall, we did see a better glucose profile as well as better sleep patterns and less rate of obstructive sleep apnea in subjects with glucokinase compared to other types of MODY. This study will need to be replicated. We need further studies to understand more this intersection between sleep and glucose in subjects with MODY. I wanted to take the opportunity to thank the subjects that were part of the study for always helping us advance science and learning more about how different sleep disorders can affect people with MODY. I also wanted to thank the organizing committee for letting me share the results with you. Here are some references. These are the 2 studies that were published if you desire to learn more about them. Thank you.
Awesome. We are going to move on to Dr. Dickens. Dr. Dickens, do you want me to continue to share? I apologize, I forgot what we decided.
I'm happy to switch over to share.
Okay, let me stop the share then. Perfect.
Okay, let's see if I can do it correctly. Okay, does that look good? Thumbs up? Okay, good. All right. Thank you so much, everyone, for being here and for giving me this opportunity to talk about this really important and interesting topic about GCK and pregnancy. My name is Laura Dickens. I'm an adult endocrinologist at the University of Chicago. I'm also the director of our diabetes and pregnancy program. All right. And so, at this point, everyone has a very good understanding. We've had this excellent background discussion about GCK-MODY. You may be less familiar with the specific considerations about glucose in pregnancy, and that's an important topic to understand before we can think about this sort of overlap in the specifics about GCK in pregnancy. So I just want to spend a moment talking briefly about generally diabetes and pregnancy to get us started. And we've talked some about different types of diabetes, and the way we frame this in pregnancy, if someone has diabetes, either type 1 or type 2 before becoming pregnant, we'll call it pre-existing diabetes. And that's about 1 to 2% of pregnancies in the US. Sometimes people are unaware of their diagnosis, so we have to think about that, especially if we find diabetes in the early part of pregnancy. It could be undiagnosed type 1 or type 2, or it could actually be GCK. Now, gestational diabetes is a different entity, and an important distinction to make here is that with gestational diabetes, high blood sugar develops during pregnancy and someone who didn't have diabetes before becoming pregnant. The reason this happens, there are hormones produced by the placenta to promote baby's growth that cause progressive insulin resistance in the second part of pregnancy. If an individual can't compensate and make more insulin, then they end up with high glucose. Gestational diabetes is common. It affects about 8% of pregnancies in the US. We're really diligent to diagnose diabetes in pregnancy, and we're really strict about how we manage it because there are potential complications for mother and baby. The risks of high glucose vary throughout a pregnancy. They can be different between type 1, type 2, and gestational diabetes. But the way I typically explain it to patients is early in pregnancy, high glucose can increase the risk for things like miscarriage or birth defects. In later pregnancy, high glucose can increase the risk that babies grow large, may have a difficult delivery or need a C-section, may have hypoglycemia after birth, and a risk for maternal preeclampsia. The good news is we can lower the chance of all of these complications of high glucose by keeping the glucose essentially normal with the strict targets that are listed here. Generally speaking, we reach glucose goals in pregnancy with lifestyle measures like nutrition and exercise, and if needed, medical therapy with insulin. Now, many of you on this call, if you have GCK, you're looking at these targets and thinking my blood sugar is always above them, and that's completely accurate. We'll talk about what that means. Okay, so more specifically, how does GCK affect pregnancy? So the first thing I'll say reassuringly is that studies have shown no increase in miscarriage or birth defects. Those are really risks that can arise from high glucose in early pregnancy. So this essentially tells us that that mildly high glucose of GCK doesn't cause issues or necessarily need to be treated in early pregnancy. However, GCK has an important impact on baby's growth and birth weight. So birth weight is highly dependent on whether baby inherits that GCK mutation or not. And we'll remember GCK is an autosomal dominant condition, so the chance of inheriting that mutation is going to be 50-50. It's a coin flip. So babies that inherit that mutation are going to have normal birth weight. You see it in this graph here, average birth weight 47th percentile when a baby inherits the mutation. If the baby does not inherit the mutation, they're going to have a significantly higher birth weight by about 1.5 pounds on average. And you can see in the graph, that's the 85th percentile for birth weight. All right, so I'm going to explain this in just a little bit more detail because it's an important concept to understand. So on the left, if the baby inherits the GCK mutation, essentially, baby's going to share that mildly increased glucose set point. So they're actually going to sense in the uterus that the blood sugars are normal for them. So baby's going to grow normally, birth weight will be normal, no treatment is needed to lower mother's blood sugars because again, baby's perfectly happy with the mildly high numbers. So the situation on the right here, if the baby does not inherit that mutation, they're going to sense mom's mildly high blood sugars to be abnormal. And then we run into the same risks we have in other pregnancies affected by high blood sugars, essentially the risk of baby growing large, difficult delivery, and other complications. Okay, so how do we determine this really key point? Does the baby have the mutation or not? Because that's really going to impact what we can expect for growth and if treatment is needed. So there are invasive forms of testing like amniocentesis that we don't recommend because those procedures carry a risk of miscarriage. So the current standard is that we use ultrasound measurements essentially to infer whether the baby has the mutation or not based on their growth trends. And the principles of managing GCK in pregnancy are summarized on the right. So no treatment in early pregnancy. Again, there's no increased risk for miscarriage or birth defect, so we don't need treatment early on. Then beginning at 26 weeks, we should do serial ultrasounds every 2 weeks. We pay particular attention to the baby's abdominal circumference. How big is their belly? Because that's a good marker of the effects of high glucose. So if the growth is normal, the abdominal circumference is normal, no treatment. If the abdominal circumference is large, and we'll typically say once it's over the 75th percentile, we'd consider it to be large, then we can infer that the baby did not inherit the mutation. So they're sensing those blood sugars to be high. And in this case, we'd recommend using insulin and aiming for those typical pregnancy glucose targets to lower the risk of large baby size complications of delivery. So this all sounds really good in theory, but in practice, it can be really challenging. So a couple reasons this is difficult. When we do decide that a baby's growing large, we think they don't have the mutation, we're going to use insulin, it's still really hard to bring the blood sugars down to typical pregnancy targets. And this is something that's pretty well recognized with glucokinase, is that high doses of insulin are needed to overcome this set point. And kind of going along with that, the babies without the mutation, even when we're using insulin, the rates of large size and rates of C-section are quite high. So it seems hard to really move the needle on treating and lowering the glucose and slowing that accelerated growth. So based on those couple facts, some people suggested maybe we should use insulin early on in all cases. Maybe the issue is we haven't had enough time or enough opportunity to be aggressive with insulin and really bring down the blood sugars. However, point number 3 is why that can potentially be a concern, and that's because there are side effects of insulin, namely hypoglycemia, low blood sugar. And if we're using insulin early in all cases, half of babies never needed that treatment to begin with, right? If they inherited the mutation, they were going to grow normally. And we're putting moms and babies at risk of hypoglycemia, again, where they may not need it at all. Okay, so interestingly, this is kind of relatively newer information. There was some data from a study in 2025 that kind of looked to answer this question. Should we start insulin early in all pregnancies with GCK, give ourselves the best shot of good glucose control and slowing that large baby size, the accelerated growth? Or should we wait until the ultrasound monitoring makes it clear that the baby doesn't have the mutation, that we really need treatment? So I summarized a little bit about what they did in this study. They enrolled 45 people with GCK. They allowed the patient and physician to choose a treatment strategy. It ended up being about half and half. So the MG group that's listed first, this is the early insulin group. So everyone started insulin early at around 8 weeks gestation. And in the FG group, so this is the growth monitoring group. And here they only started insulin if the fetal abdominal circumference was large, or if glucose levels exceeded certain safety limits that they had set. Interestingly, in the second group, 75% of people ended up starting insulin. So most people were on insulin anyway, but in the second group, they started it much later at a median of about 26 weeks. And the big take-home point from this study is that there was no difference in large baby size between these two groups. Whether we started insulin earlier or later, baby size was no different. So this tended to refute the idea that we should be using insulin early in all pregnancies with GCK. It didn't seem to make a difference. This study did, interestingly, show frequent hypoglycemia, and that may have been limiting. So limited the ability to use insulin, to its greatest extent because of the low blood sugar risk. All right, so it seems like early insulin for all is probably not the right strategy, carries some risks. So there's been interest in strategies to more accurately and even earlier determine whether baby has the GCK mutation. So we can target treatment just to those pregnancies where we know baby doesn't have the mutation, the risk is there for large size, and they really need insulin. And you guys may be familiar with non-invasive prenatal testing, or you may hear it called cell-free DNA. So this is a commonly used non-invasive test done for chromosomal abnormalities and other genetic conditions that's been studied for GCK as well. So essentially a sample is drawn of mom's blood in the later first trimester, early second trimester, and you can test for fetal DNA within mom's blood to make a diagnosis of a fetal condition. So the Exeter group in the UK pioneered this strategy. They published a series of 38 pregnancies comparing non-invasive prenatal testing with ultrasound monitoring, seeing how accurate each was for determining baby's GCK status. And as you might expect, this genetic testing, non-invasive prenatal testing was highly accurate at identifying which babies inherited the mutation. It was 100% sensitive compared to our ultrasound measurements, which were only about 53% sensitive. So it's really exciting, really encouraging, but unfortunately, this testing is not available outside of limited research studies, which is something we're hoping to change. All right, and so that was a little bit of a whirlwind, but wrapping things up, this is a summary about a couple important points from the discussion about GCK and pregnancy. And I want to emphasize our future directions. One is an important project we have in the works to develop a CLIA certified non-invasive prenatal test for GCK. So that means it's a test that any provider could order from a commercial lab. We first need to show that this test is accurate in that setting. So we'll be looking to recruit pregnant people with GCK to participate in that study. If you're interested in that study or have questions about it, please, reach out to us, let us know. I'm also interested in different insulin strategies. So we have some newer insulin pumps that work a little differently. Maybe these could better control glucose in those settings where we do need insulin and be a little bit more effective at controlling growth. All right, so that's all that I have. Thank you again for your time, and happy to answer questions in the Q&A or if anyone's interested to reach out.
Thank you so much, Dr. Dickens. We're going to have Dr. Hengeist from NIH take over next.
Great. Thank you very much. Just making sure everyone can see my slides.
Yep,
Thumbs
they
up.
look great.
Perfect. So thank you everybody for taking the time to attend the webinar. I'm Aaron Hengist from the Intramural Research Program of the National Institutes of Health. And today I will give a quick overview of a study we are recruiting for investigating the effects of ketogenic diet on metabolism, led by Dr. Stephanie Chung and myself. And before I get into the details of the study, we're based at the Clinical Research Center in Bethesda, Maryland, which is the nation's largest hospital devoted entirely to clinical research, and this is where the study would take place. And in this study, we're interested in measuring how the body responds to a very low carbohydrate ketogenic diet. And in this diet, staple carbohydrates like potatoes, rice, and bread are removed from the diet and replaced primarily with fat. And it's not necessarily unhealthy fats. It's a mixture of nuts, seeds, oils, fish, and as well as animal fats like bacon and eggs. And in the study, we're not reducing the amount of calories you eat. We're just switching the types of foods you eat. So it's not a weight loss or a weight gain study. And the diet is called ketogenic because the body makes ketone bodies as an alternative fuel for your brain and other tissues and organs. And ketogenic simply means producing ketones. And previously, work at the NIH showed that sleeping energy expenditure increases at the start of a ketogenic diet, around days 4 and 5. So when you're lying in bed, not moving much, the body is burning more calories when you switch onto this diet. And we want to try and explain the biology of this effect. And like I said, when you're lying in bed not moving much during sleep, the liver contributes a large proportion of how many calories you burn. And we know that ketogenesis, the process that happens when you start this diet, occurs in the liver. So this increase in sleeping energy expenditure at the start of the diet might be because the liver is producing more ketones. We are recruiting adults with diagnosed GCK-MODY, including males age 18 to 65 and premenopausal females age 18 to 50. So what would you have to do to take part? Following some remote and in-person screening, you would attend a single 9-day visit at the NIH Clinical Center here in Bethesda. And for the first 4 days, you'll be eating a standard American diet, which has typical foods and a moderate carbohydrate intake. It should be roughly similar to what most people are consuming at the moment. And then you would switch onto this ketogenic diet for 5 days. So it's quite a short-term intervention. And the first 2 days would be getting used to the environment. And then we do a series of tests followed by a break at the start of the ketogenic diet, and then repeat those tests at the end of the ketogenic diet. So the primary measure of interest is how many calories you burn whilst asleep, which is measured using a special room called a metabolic chamber. And it's a small bedsit with a TV, an exercise bike, a bathroom and a sink, and a telecom system so you can communicate with the nursing team. And you would sleep in this room every night for the testing phase, so 7 nights in total, and have 2 24-hour periods in there as well. The rest of the time you'll be downstairs in our metabolic ward, which has larger ensuite rooms. So you'll sleep in there the first 2 nights and spend most of your days on that ward. And like I mentioned, we'll do a series of tests during the standard diet and repeat these during the ketogenic diet. And these will include meal tests with blood samples to understand how your body responds to food during the diets and measure how much dietary fat you are burning. We'll do infusion tests to tell us how many ketones you're producing and how much fat you're burning from body stores. And we'll do MRI scans to tell us how much fat is stored in your liver. And we also do 2 very low dose X-rays to measure your body composition, which is how much of your body is made up of bone, fat, and other tissues. So what would your journey be through the study? Well, initially we would call you to ask some questions about your lifestyle and medical history and see if you might be a good fit for the study. Then if everything looks good, we would do a remote consent review over the phone just to go over everything, all the details of the study in more detail and answer any remaining questions that you have. And then after the consent, we're able to do some more screening activities like review blood tests and organize a meeting with our nurse practitioner and research dietitians to discuss more details. And then we'll organize a in-person visit, which day 1 will be some in-person screening activities just to confirm that you're safe to be a participant in the hospital. And then the 9-day visit will commence. And you will be reimbursed up to $1,945 for participation, which will be paid at the end of the study. So thank you very much for your time, and please contact us if you're interested in hearing more about the study. Here's my email address and phone number. And I appreciate there are logistical challenges for potential participants with travel, but we don't want this to put you off from getting in touch. So please rest assured that emailing and texting is not a commitment, and you can change your mind at any time, even if you sign a consent form. So we want to hear from you and see if we can make the visits work. So yeah, I appreciate you all for listening today.
Thank you so much, Dr. Hengist. Again, if there are questions, feel free to put them in the chat, or you're welcome to reach out to the NIH team directly as well. So we're going to move into the Q&A portion of our talk today. And I will start by reading some questions that we received by email. Thank you for those that have submitted email questions. And I guess I will just try and direct them to whoever I think is best, but panelists, feel free to chime in if you have additional thoughts. So one common question that we've been getting is about medication use in GCK-MODY. So maybe Dr. Phillipson or Dr. Naylor, if you could comment on kind of generally, is treatment recommended, treatment with medication recommended in GCK? And there's specifically some questions about whether GLP-1 receptor agonists are useful.
Maybe we can take turns. We might have some additional stuff. So I can handle some of that. I think that if a person has what we consider now sort of the usual GCK syndrome, so weight and body mass index in the normal range or even slightly below. So if you are familiar with BMI, oftentimes people with GCK have a BMI of less than 25, 23 often. So not obese, and blood pressure is great and cholesterol is great. All of those things would suggest that no medicine is needed, that long-term studies and studies going sort of in a slice of life, looking at parents, grandparents, as well as children, suggest that treatment is just not necessary. I would say the one, besides pregnancy, which you heard is a special case, if there is obesity or there can be concurrent type 2 diabetes. So that's a different story, and we're learning more about that. And I don't know if Dr. Naylor, you want to pick up on that, or I can as well.
I would just say a question came up, for instance, with PCOS, now termed PMOS. We know that PCOS and PMOS, very similar to having a BMI that's in the overweight and certainly in the obese category, is strongly connected to type 2 diabetes. And so because we expect levels of overweight and obese BMIs to be at the population prevalence, we expect rates of PCOS or PMOS to also be at the population prevalence, which means some individuals with GCK-MODY will have these other things. And really the goal, again, of predict having more individuals with GCK-MODY and data collected the same way is where we really hope to be able to start to say something about these co-occurring things. It's very difficult, again, when you have a condition that's characterized by mildly elevated blood sugars, mildly elevated hemoglobin A1C, to know where the GCK could possibly end in something like the influence of PCOS or having a BMI in the overweight or obese category starts. And so that is definitely the gray that we hope that we can really start addressing through national and international collaborations.
Thank you both. Dr. Naylor, maybe if you want to start with our next question. There was a series of questions about diet, how impactful are diet changes, particularly low carb, on reducing A1C. Can people with GCK eat sweets? Kind of those types of questions.
Yeah, so I'll start with the punchline, which is we all should be, trying to be healthy, and that is true for people with GCK and without. Um, can we all impact our blood sugars and our A1C by having a very, very strict diet? Yes, I can, and I don't have GCK-MODY, and people with GCK-MODY can as well. The question, though, between being able to do something and having a meaningful impact are different. And that's the part that's really difficult. And also being worth it, right? There's the trade-off. And so right now, I would assume for myself as a person who tries to eat relatively healthy, and I try to exercise, and I try not to do the, sort of the list of the no's, that I'm probably increasing my healthy life expectancy. But if I eschewed all carbohydrates and made myself very miserable because I like carbohydrates, I don't, maybe I'd get 5 more days of extra, of kind of healthy living. And for me, that wouldn't feel worth it. And people living with GCK-MODY should think of it the same way. We can be extremely, extremely, extremely healthy in a way that feels hard. And we have to ask ourselves if it's matching. There isn't any data to suggest that doing all these extra things in GCK-MODY is really impacting kind of the overall arc of sort of how long you'll live, how healthy you'll live, those sort of things. So I think generally having a healthy diet is really important. But understanding that making a specific difference for your condition that would be different from the general population without GCK-MODY, there's no evidence to suggest that we're able to do that through diet and exercise.
Okay, thank you. Dr. Dickens, we have a question about GCK in pregnancy. There was a question about the C-section rate in GCK pregnancies and whether that's different than the general population.
Yeah, that's a really good question. And this is going to depend pretty strongly upon whether the baby has the mutation or not. So like we were saying, in my slides, if the baby doesn't inherit the mutation, we're at risk for large size, and there are higher rates of C-section. It varies in the studies. This can be between maybe 40%, and one study was as high as 70%, but around 40 to 50% is generally what we see. Now, this is complicated because there are many reasons to have a C-section beyond the GCK or the glucose control. And there's differences depending where you live and how providers practice. But definitely without the mutation, babies grow larger, higher rate for C-section. Now, the flip side, if the baby has the mutation, growth is normal, we wouldn't expect a higher rate of C-sections in that case.
Okay, and kind of continuing with the pregnancy questions, there was a question in the Q&A, any data on VBACs in mothers with GCK-MODY?
I'm not aware of any. That's a good question. And I think it would depend, again, very much on growth and growth trajectory. But my thought would be in a normally growing fetus, this diagnosis shouldn't preclude the opportunity to VBAC if otherwise you'd be able to. VBAC meaning vaginal birth after cesarean for those who may not know.
Great, thank you. And then a couple of questions about kind of monitoring. So maybe Dr. Naylor or Dr. Phillipson, some questions about like how often should A1Cs be checked? Do you recommend yearly checkups, for example, to make sure A1C is stable? What is the outlook like if, otherwise healthy? What's the outlook like for GCK-MODY over time?
I will just start with what I do and have Dr. Phillipson add to it. I will admit it makes me feel good to see a A1C annually. I will also say that I don't think it's truly necessary. But I think sometimes it just tends to give everybody a little bit of peace of mind. I would remind people, again, I mentioned it briefly in the slides, that everybody, the natural history of our blood sugar levels and our A1Cs is that they go up as we age. And so understanding that that's going to be true inside and outside of GCK-MODY is important as you think about them being stable. I really think about it as whether or not they are in a range of expected for GCK, which is really 5.6 to 7.8% in, big cohort studies.
Right. I would just say that some experts, and we often mention our friends in the UK at Exeter, Dr. Hattersley's group in particular, who have been strongly on record as saying once the diagnosis is made, unless there's some other change in your health, like you gain a lot of weight or something else happens to you, that A1Cs, in fact, should be avoided because all they do is make you unhappy. They confirm that you still have GCK, which is a lifelong situation, but from everything you've heard today, there's not much impact, even with high doses of insulin. So why get an A1C? That's what Dr. Naylor said. If nothing else, is to make sure, yep, things are about the same, and you go back to what you were doing. But I think all of those things have to be individualized. Some doctors will insist on getting an A1C. Some doctors insist on treating an A1C, so that we get into a whole nother situation that several people have talked about. I see there are a bunch of questions about pregnancy again. I think that is one of the most difficult issues. So let's maybe try to get to a few of those with Dr. Dickens.
Dr. Dickens, do you want to take any of those questions, maybe verbally instead of in the
Yeah.
chat?
I'm trying to keep up. So any studies on non-GCK mothers of GCK babies? So I think the question here is maybe getting at, when the mutation comes from dad. And this is it really gets kind of into our understanding of how glucose affects growth in babies. And so if a baby inherits a mutation from dad and mom does not have GCK, the baby actually is at risk for being small. And the idea here is, baby would be very happy with a fasting glucose of 110, and mom's fasting glucose, if they don't have diabetes, is 80 to 90. And when the glucose is lower than what your set point is, again, babies can have smaller growth. So that's an interesting sort of nuance to it. The trick is there's not really much that can be done. We can't raise mom's blood sugar, for example. So is an interesting circumstance that comes up. And then I saw another question: if the baby is expected not to have the mutation, is it recommended to schedule an induction? And again, if the growth is normal, there shouldn't be an indication for any kind of earlier delivery, like we would for a diabetes diagnosis necessarily. But obviously within a pregnancy, there are many other circumstances that may impact the recommendations for delivery timing. But again, we shouldn't think of it like diabetes if, as we've said, this isn't diabetes. And if growth is normal, we shouldn't need to do an earlier delivery.
Great, thank you so much. There was one other question in the Q&A about kind of type 2 diabetes risk, and maybe Dr. Phillipson or Dr. Naylor, the question of how would I know if I develop type 2 diabetes concurrently with GCK-MODY, and what A1C level would require treatment?
So generally speaking, it doesn't happen. So we don't want people to worry about it. I think in some of the studies that are going on, so there's a big study in England called the UK Biobank, and there's studies here called All of Us. And we are finding that there are people who seem to have honest to God type 2 who also have GCK. So we're still learning what that means. Typically, though, it involves weight gain. It would involve a strong family history of type 2 diabetes or obesity in other family members or your parents. So it does come down to what Dr. Naylor was saying, that if you're concerned about it, then test. Usually, if everything stays the same, your weight stays about the same, your size, your activity level stays about the same, there's no obvious reason why you should develop type 2 diabetes on top of GCK. So we don't see that at all. I mean, you saw in our slides, we have over 600 people that we ourselves follow here, and there's hundreds more in different places around the world. So it's not something that happens that we know about, again, unless something else happens. Dr. Naylor, do you want to add to that?
Yeah, all I would say is, so yes, just like Dr. Phillipson said, if there are like clear changes and in a way that would infer a risk for type 2 diabetes, and the A1C is outside of the range of GCK, then absolutely. I should also say that there isn't a reason that anybody, like the background population of type 1 diabetes, should also be for GCK-MODY at the background population. We do have people, not many, because again, it's a background population, who have GCK-MODY and type 1 diabetes. And then you've got to treat type 1 diabetes. What I will say for the few people who, sort of clearly have co-occurring type 2 diabetes with their GCK-MODY, the other thing that you have to think of is the GCK-MODY, of course, is genetic, and it doesn't go away, which means your body will continue to counter-regulate. That is, if your blood sugar goes too low, rather, not raises, goes too low, our bodies are designed to kick in and raise our blood sugar, and that will still happen. That set point won't change. And so if you do develop, co-occurring type 2 diabetes with risk factors that clearly, were the reason that you were checked in thinking of this, trying to adhere to usual targets appropriate for someone with type 2 diabetes without GCK-MODY, like that doesn't work either. So there's lots of, that intersection, that gray is definitely a significant focus for us, just as, as the best management in pregnancy.
So just to say that, some of the comments here, and this one is, I think unfortunate, the biggest risk factor for GCK-MODY is the medical establishment. Well, it isn't the medical establishment. I mean, that's not fair to say. It's sort of, if you think about what happens in medical school, and if you have a general practitioner, they may get a few hours of diabetes education and they get a few seconds of MODY mention. So unless someone is a diabetologist who really specializes in treating all aspects of diabetes, they may not be up to speed on diabetes. And generally speaking, we found that once we can help educate them, then we can turn things around. There are occasional doctors who are so busy that they, can't read what we send them. That has happened. But what we are seeing in the chat as far as frustration with either lack of diagnosis or misdiagnosis, delayed diagnosis, incorrect interpretation of the blood tests, this is why we're doing this. I mean, we've been doing this now on and off for 20 years. And as I said at the very beginning, this MODY2 GCK was one of the first ones identified around 1995-ish, between 1993 and 1990. So you would think by now it would be well understood and all the doctors would know about it. It's just not the case. I would give a shout out to the pediatric doctors who are way better than most internists, and Dr. Naylor could speak to that. I think for a child to have high blood sugars often now promotes this whole thing we talked about. Do they have type 1? But have testing. So the whole thing that we try to emphasize is making a specific diagnosis. Diabetes ought not to be diabetes. There's now upwards of 20 different kinds. The right doctors who who should know about this are testing. So Dr. Naylor, so you'll appreciate that I think all the pediatric endocrinologists and many pediatricians are more aware of these things.
Well, I will say, I mean, while I'll smile and accept the the characterization, I think that part of it is because for children, we really have to make sure we're never missing type 1 diabetes. So checking those antibodies, usually all 4 that are available happens in the pediatric clinic and does not always happen in the adult clinic. What I will say, yes, unfortunately, as Dr. Phillipson said, like monogenic diabetes is a very small part of everything that doctors learn, particularly if they're not in endocrinology, and even if they are. And it is very often that we find that people in the registry have to advocate and keep saying, this doesn't make sense, this doesn't make sense. That's why we try to be, available as for, through the registry. Please always use the general registry email and not our personal ones, because at least I am terrible at email, but the general monogenic registry has many eyes so that emails don't get lost too often. We have a clinical decision support tool. Maybe some of you on the call has also contributed to that effort, which we will hopefully sometime in 2027, if not a little bit earlier, make available to clinicians. So not everybody has to be an expert, but they can get to this type of information. And you can as well, kind of, something more ready to share with doctors. So lots of ways that we're trying to support. We do know that a lot of you have had what we, call a huge diagnostic odyssey to get to your diagnosis and some missteps. And so we are grateful for, all that you do to contribute to help us understand how best to help you as well.
Yeah, I think we're wrapping up. I mean, I think there are people who are thinking of questions. Please write them down and send them to us. I see there's one, does GCK cause protein in the urine? The answer is generally no. Just like GCK doesn't cause eye disease or vascular problems or foot disease, it ought not to cause protein in the urine. If there is protein in the urine in someone who definitely has a known verified GCK mutation, and that's very important. I mean, we need to verify the mutations, and we're happy to look at if that. Sometimes the mutations come back with this. We didn't talk about this very much. The initials VUS, which means variant of uncertain significance. And if that is your test, then maybe you don't actually have GCK at all, but there's a variant that are not causing GCK. So that has to be interpreted by an expert. So GCK by itself should not cause kidney disease, should not cause protein to appear in the urine. But there are other reasons why protein could appear in the urine. So you could have a separate issue. And so if that's the case, you need to look into that. So sadly, yeah, so sometimes we have the question in the next chat, my GCK son's doctor recently because I'm eating too many sweets. That's painful for us to hear. We can certainly, again, provide background information, a letter, references, chapters that might help. I mean, we've seen sometimes we provide all that stuff and it doesn't help. So we continue to try to educate and explain what this situation is, because it's not that uncommon. With the numbers we provided, we think somewhere between 100 and maybe 250,000 people in the United States have GCK, 95% of whom remain undiagnosed. So
sorry, I want to say one of the things that we are also compiling is a list of doctors who either have feel like they have some good knowledge of monogenic diabetes, or have sort of self-identified as being really amenable to learning. And so sometimes you do need a different provider if you feel unheard, particularly if you kind of consistently are having to guide your own care. There may be other ways we can support. So definitely please reach out, again, with your questions, send them to the general monogenic diabetes registry email, and we will continue to answer them even after the webinar.
We did have a couple of questions in the Q&A that I just wanted to address with everyone about how to obtain genetic testing, or family members that may benefit from genetic testing. Unfortunately, we're not able to offer research-based genetic testing at this time via our registry, but I just wanted to encourage anyone that has questions about how to obtain testing to still please email us at monogenicdiabetes@uchicago.edu. Genetic testing should really be standard of care at this point for GCK-MODY, and we're very happy to help you and your healthcare providers think through how to obtain that testing. I think we've answered most of the...
I can see one more. So this one I think is unusual. If you're using GLP for weight loss and have GCK, so the first question is, why are you doing that? So, again, most people with GCK will have BMIs under 25, which oftentimes is just right. So I would think hard about why that person wants to lose weight. Will it still work for weight loss? That's interesting. I think it should, but there's no data. I don't know if Dr. Naylor or Dr. Dickens, have you ever heard of that? So if someone has normal weight, so BMI of 23 to 25, and starts using a GLP-1, they will eat less. They should lose weight. I don't think that having MODY-2 will have anything to do with it. What do you think?
I concur. I would say, obviously, it isn't uncommon. Again, it does seem that people with GCK-MODY might have some protection against weight gain, but it is uncommon for us as we get older to pick up some weight. And I do think that there isn't a reason that the risk of GLP-1 receptor agonist mechanistically, there's no reason it should be increased in anybody with GCK-MODY. We expect it to respond the same, but yes, again, like obviously, if it is for weight because there's weight gain, we expect it to.
But contact us, and it might be interesting.
Yeah.
It's potentially possible we could write up a case report and have other people learn about it. I don't know if anyone else wants to speak to that, but I think it's interesting. There you go. So another person who it worked with. So this is why we have the registry, because sometimes we don't even know what questions to ask. And for you to volunteer this information is really so appreciative. So we are so appreciative. And we may actually then try to ask that question in future outreach efforts and publish it. And I think other doctors and other people at GCK would like to know that that it can be done. It can be done safely, because it is now an experiment that you're doing without a doctor. So, all right, that's all I have.
Yeah, again, I would say thank you, everyone, not only for being here, but again, also for being a part of the registry or telling other people about the registry. It is, critical for us to understand GCK-MODY better. Just as we said in the last few minutes, the use of GLP-1 receptor agonist, nice, someone didn't change the A1C, but it kind of does its known job. Thank you for people who express your frustration. We are in this with you, but also for people who have seen the needle moving, which encourages us. So thank you to everybody for your participation, your attention, and again, your support through kind of co learning together.
Thank you all. We'll be wrapping up for today. If there were any lingering questions, feel free to email us at monogenicdiabetes@uchicago.edu, which we've also put in the chat. And we'll keep everyone aware of future events. Thank you again for being here.